5, very interesting topic for us to learn, brainstorm, and see how best we can provide quality care. And I hope we are audible from on our side and on your end. So I just want to assess if we are audible. Abigail Abenzu, good afternoon.
We can hear you.
Great, thank you. Much appreciated. So in our midst, as our presenter, we have Dr. Kozia Ziambo, who is a pediatrician and HIV expert with a different portfolio. We have as well a good number of experts, Dr. Chimika Piri, who is our HIV prevention advisor at MOH, Dr. Manzi, who is our pediatric program officer at Lusaka PHO, Dr. Muya, Director, Pediatric Center of Excellence. We have Dr. Oscar Mwinde, our pediatrician at CDC. We have as well Dr. Bupe Musonda as our HIV pediatric advisor, and that is the aid of pediatrics in the PROUD-Z project at CIDAS. Myself, as your presenter today, I'm Dr. Emmanuel Mungomba, HIV a technical advisor at FHI 360. So once more, you are welcome. This session has actually been made possible with the technology assistance done by Chatonda and the coordination of Etambuyo under the leadership of Dr. Naik Neo. So this is how the team is set today, and our case presentation will be done from Senanga with the participation and the leadership of the lead mentor Western Province. Maliwa Likezo will be our presenter for the case today. So once more, network, you are welcome. Let's follow the eco etiquette. We get muted and we can only speak once we are given a go-ahead, and also utilize our chat box at the maximum. So once more, team, you are welcome. At this point of time, I would request Dr. Kozia Ziambo to greet the people and briefly introduce yourself, and we'll have our session for today started. Dr. Ziambo.
Thank you so much, Dr. Mngomba. And thank you, colleagues out there. We're looking forward to having a great session with you. And I'm here just to share with you some of the strategies that we can employ when it comes to pediatric case finding. And we'll talk a lot about that, and we'll invite a lot of questions. Want you to participate actively, and please do participate in sharing some of your experiences on the ground, because I know this is quite a big problem that we're having on the HIV program. So thank you so much for joining, and I look forward to a great session. Thank you, Dr. Mo.
Thank you very much, Dr. Ziambo. We are very ready to learn from your expertise and your huge experience in the HIV program, and having the experts we have on the panel. We are very much assured that today is another day when it comes to the practice in active case finding in pediatrics. So once more, Dr. Kozia, you are welcome for finding time for us on this ECHO platform. So I will invite you for today's session. Over to you.
Thank you so much, Dr. Mungomba. And today we'll be looking at pediatric HIV case finding, moving towards the first 95. It's been quite a big journey for the pediatric program. And we'll be able to discuss a few challenges, a few strategies, and we'll see how we move on from here. And so, no disclosures, but I just want to acknowledge contributors to these slides. We have Lusaka province, Western province, and Wapula province that managed to contribute some work and put this up together with their support. The session objectives, we want to look at the country updates and country updates on HIV case finding. We'll also touch a bit on the global status and the situation. And I want to highlight the challenges with HIV case finding in children. And these challenges will actually be looked at in terms of geographical, in terms of health systems, in terms of individuals, socioeconomic, and these are the inputs that we have had from different provinces. And we also want to discuss strategies to improve case finding in children and looking beyond EID. Therefore, you, Dr. Mungomba.
Thank you, Dr. Ziambo. So this is our poll question, number 1. We answer by true or false. Globally, around 63% of the 1.7 million children living with HIV know their HIV status. True or false? So we are going to launch the poll. And take note that this is anonymous and we won't see your responses. Again, the question reads, globally, around 63% of the 1.7 million children living with HIV know their HIV status. True or false? So we are at 50% of participants. Dr. Ziambo, quite a very engaged network, and we'll close the poll in the next 5 seconds. Okay, so we have 2 seconds to go, network. And we'll end the poll here. So 59% believe that true is the correct answer, and would love to learn from you what is exactly the correct answer.
I would like to know why people picked false. Okay. Yeah, and the group here, we do have some people here as well that are participating. They didn't poll. So let's move on. Let's find out what are the global statistics. So we know, and globally, by UNAIDS and UNICEF, that pediatric case finding globally faces significant challenges. And the majority of the children that are infected remain undiagnosed and untreated despite the progress in reducing new infections. And so we have about 86% of estimated 1.7 children living with HIV live in the sub-Saharan region, and which is quite a very big problem if you compare. So like really over 80% are in the sub-Saharan region, and that's a big problem. But then of those 1.7, 63 actually children who know their status. So we have a huge gap of about 37% that don't know their status. So that's a huge gap. We need to find those children. And of those that know their status and on treatment, 86% of them are virally suppressed. Fair, but not good enough. We want to go beyond 95 when it comes to suppression levels. And it's a big problem globally. And so when you go to the right, you see another cascade. Now, this cascade is actually looking at the denominator, which is constant, which is the estimate. So if we estimate that we've got 1.7 children living with HIV, of those, only 47% are actually virally suppressed. And of those, of 1.7 million, only 55% are actually on treatment. So when we compare with the population level denominator, you find that we are way, way, way below. Only 55% of the children know their status and are on treatment, which is quite a big problem. But if we look at the cascade, the 95, 95, 95 cascade, that's where we have a bit of friendly, where it's about 63%. And we can see that in the third 90, it's about 86% are virally suppressed. So this is another chart that shows us, according to the regions, showing us the children that know their status and those that are virus suppressed and those that are on treatment. And so you will see that when we look at our interest is Eastern and Southern Africa, we see that 29% do not know the HIV status, a very huge gap. And then only about 10% who know their status are not on ART. That's another very big gap. 10% know their status but are not on ARVs. And when we go to the blue section, we have children who are on ART, not virus suppressed, 9%. And that's also very important for us to know. But we have about 52% on ART who are virus suppressed. And this is Eastern Southern Africa region, a very important indicator and parameter for us to take note.
Thank you very much, Dr. Kozia. So far, very good information and insightful being shared. So we have gone into our poll question, 2. It is also a true or false. Over 80% of the estimated children living with HIV in Zambia know their status, true or false. So we are going to launch the poll, and we have only 10 seconds. So read again the question. Over 80% of the estimated children living with HIV in Zambia know their status, true or false. Okay. This is very, very, very good, Dr. Ziambo. Our network is really engaged. And
I think we have got pediatric champions out there.
Yes, I think we have most of them on the network. Yeah. So far, in between the true and false, we are like divided 50-50.
Almost.
We are yet to see network. In the next 2 seconds, we'll end the poll. Okay. So this is what has come out. We have 44% believing that true is the correct answer, against 66% believing that false is the correct answer. Over to you, Dr. Ziambo.
Yeah, thank you so much for that. Let's find out what is correct. So this is a cascade according to the, as of December 2024, Spectrum and as HMIS data. So it is true that over 80% of the children know their status and are on treatment. And of those that know they are on treatment, know their status, at 88 are on treatment. And then of those that are on treatment, 95 are actually virus suppressed. So generally in the sub-Saharan region, we seem to be doing fine amongst the children in terms of virus suppression, but we have about an 18% gap. And that 18% gap equates to about 11,000 children that we need to find. And once you compare it to the adolescents, who are 95% know their status, and 92 on treatment, and 95 are suppressed, compared also to the adults, the chart on top, where we've got 98, and 97. The children really remain behind when it comes to case finding. So now that we've looked at the performance, I thought we could also look at how we are doing in terms of case finding. So this data is based on, according to May 2025, and also it's against the estimates that are via the Spectrum estimates. And so you see a few offline results like in Lusaka and Western. So what we see here is that the orange ones are the gaps. Those are the children not yet on treatment. And also on your left is the general population. On your right-hand side is the children. So let's look at the children's side. You see that at national level, we still have about a gap, and that's about 11,000 or so who don't know their status. Then we have provinces like Northern, Northwestern, Mchinga, Lusaka, and Wakula showing quite some a gap in terms of the children that don't know their status yet. And I thought of sharing this important slide here to show us that there is a gap that we witnessed in February, and we saw a downward trend. And I think we are seeing a downward trend in terms of HIV testing, meaning it's actually reducing. Apart from the stopwork order that happened, we still have a downward trend. And so there's need for us to check ourselves and how we are doing and why this picture is like this. We'll move on to the next 4 questions, Dr. Mngomba.
Thank you very much, Dr. Ziambo. This is our third poll question which we are having with so 4 possible answers. So which of the following statements about pediatric HIV case finding is not correct? Which one of the following statements about pediatric HIV case finding is not correct? Is it A, there is generally low treatment coverage for children? Is it B, delayed diagnosis can lead to missed opportunities for early intervention and potentially experiencing disease progression and increased mortality? Is it C, barriers to testing, limited access to testing services, lack of provider awareness, stigma, and policy barriers related to age of consent? Is it D, incomplete cascades? Example, children identified as HIV exposed, follow up and linkage to care does not contribute to pediatric case finding. So I'll read again. Which of the following statement about pediatric HIV case finding is not correct? Is it A, there is generally low treatment coverage for treatments for children, I mean? Is it B, delayed diagnosis can lead to missed opportunities for early intervention and potentially experiencing disease progression and increased mortality? Is it C, barriers to testing, limited access to testing services, lack of provider awareness, stigma, and policy barriers related to age of consent? Is it D, incomplete cascade? Example, children identified as HIV exposed, follow up and linkage to care does not contribute to pediatric case finding. So I'm going to launch the poll for 10 seconds and we are going to provide with our answers. Okay. Okay, so network, we have 10 seconds for this poll.
I know it was loaded.
Yeah, it was loaded, but very informative.
Yeah. Very confusing. So we're picking the answer which is not correct.
Yes, so the answer which is not correct. Very good, Doc, for that emphasis. So we are not going for the correct answer. We are going for what is not correct, network.
Yeah.
Okay. So far we are at 50% network. We are waiting for your response. 5 seconds given again. Okay, so we are ending the poll in the next 2 seconds. Wow, so this is the results, Dr. Ziambo, and it is really divided, but D actually is outstanding with 72% believing that D is the correct answer, which is not correct. What do you, Doc?
Thank you so much. So, a very interesting question. So what are the things surrounding case finding? And a lot of research has been done, a lot of papers have been documented, and one of the issues that has been found out is that low treatment coverage for children also has an impact on case finding. And this might be related to caregiver-related issues such as stigma and disclosure issues. You find that the caregivers are not really interested in taking the children for treatment, or maybe they're scared of disclosure issues, and so they keep hiding the children. As you will be able to see later on in one of the cases that we presented. Delayed diagnosis also, many children are diagnosed late, and lots of missed opportunities that we see in our facilities for various reasons, potentially experiencing there may be no reagents, there may be inadequate counseling skills, and so you find that diagnosis is delayed, and later on leading to progression of disease and experiencing mortality at the end of the day. Also, testing barriers, limited access to testing services, geographical distances, also equipment, reagents, and maybe lack of provider awareness, stigma, and policy barriers, such as age of consent. When people bring their children, you find that they're not able to give consent, and so the child is not tested. And then now, this is one that people thought was not correct. And so, incomplete cascade, really what we're saying here is that children may be identified as HIV exposed, followed up and linked to care. Sometimes this process is very weak, and we have missed opportunities where we don't know the results and we lose the children, and we don't complete the whole cascade of care for these particular children. And so this does contribute, and so it's quite an important factor. Then when it comes to shift in transmission, we know that for a long time we've had this mother-to-child transmission that has happened, but now breastfeeding period seems to be quite a worrisome period. When we use our estimates, you will see here that most of the infection that affects the children comes from mothers that get infected during breastfeeding. And so this gives us an idea that we need to find ways that are being informed by data. What is our data speaking and what is our data saying? And then begin to intervene according to what we are seeing in our data. So what are the strategies for improvement? And I think these are things that we are doing on the ground. So I'll just speak generally over what we can do, and we know this. But I think what the biggest story that I would like us to pick up from this is how do we streamline all these interventions to speak to the things that are going on in our facilities? And that's what is critical. We'll have all these broad areas of discussion when it comes to strategies to be able to do the case finding, but we have to streamline them according to what we are seeing on our ground. And we have got provinces that are going to share some of the specific things that they've done to address these particular challenges that they're experiencing, and also to improve the case finding. So strengthening EID to improve access and quality EID for HIV exposed infants is very important. And strengthening EID might include quite a number of things, and that might be how the flow of patients is, how the flow of the of the DPS is how we make those movements. How we get feedback in time. Is it coming on time for us to make a decision? And that also adds to strengthening EID cascade. Index case testing, and you'll be able to see that index is one of the highest testing modalities that contributes to the positive findings. And so we need to work in such a way that we are able to index almost every woman or man that comes to the hospital who is HIV positive. And that becomes a very important component for us to do. PITC, another venture which we see is very important and also contributes to case finding. We really need to integrate HIV services and testing in routine HIV services for children so that we actually identify them early and prevent morbidity. So also community, we need to have strategic integrated community-based approach programs, outreach programs. Of course, we're not saying you come out and you just decide to go into the community and start testing. That's a very, very expensive venture and might not even give you the results. But what we're suggesting is hotspot mapping, where we actually see that in this particular area, there's these risk factors and there's these kinds of people. In this community, there's this kind of people. For example, in vulnerable and orphaned community orphanages, that's a very important space where you can actually do a community outreach and find out if those kids have been tested and the HIV status. Addressing stigma and discrimination by creating supportive environment and addressing social barriers to testing is also very essential as one of the strategies. And then at the end of the day, we need to strengthen the health systems to improve infrastructure, training of healthcare workers, and ensuring availability of diagnostic tools and treatment is very, very crucial. This is showing us also the EID and how it is performing so far. I think we've slackened, and this is an opportunity that we are missing as well in finding the children. Because once we lose them at this age, the next time that we are seeing them will be when they are older than 5 or when they've got a complicated disease. And that becomes quite a problem to treat and to manage. So, with what I've said, which is overarching and speaking to a general population, what is working on the ground? What are some of the examples can we see that the provinces are doing on the ground? So let's have a look at Western Province. HIV testing has to reach areas like Western Province. So some of the testing modalities and approaches that they're using is what they're calling KYCHS plus, and then there's the KYCHS plus, and then we've got neighborhood health committee, community-led, and then we've got, sorry, could you please just turn off your mic? Thank you. And then we have got pediatric community-based HIV testing. Like I said, very strategic places such as orphanages, drop-in centers, and then also optimization of PITCT during entry points, integration of HIV testing, as well as index services. So they managed to define this and so that we may understand the purpose of each. So what we mean by KYCS, the purpose is to enumerate and reach all children living with every woman who is receiving ART at a given facility with the HIV testing services. And the goal is to list all women living with HIV, that will be your TX-new, all those that are already on treatment at the facility to elicit the HIV status of all children living with them. This might be both biological and non-biological. And the primary goal of KYCS Plus is to elicit all children less than 19 years old living under the same roof and offer the HIV testing to them. Now, the KYCHS Plus is to reach all children who are living with every single and widowed divorced male living with HIV or men in discordant relationships who are receiving ART at a given facility in HTS. A very great initiative. We now want to target children who might be widowed, single, and divorced, even males living with HIV. And the goal is to list all these group of people at the facility to elicit the HIV status of all children living with them. And the primary goal is to elicit all those children less than 19 years old. The strategy helps with children who are missed with conventional HIV testing modalities. And also, it's important to think that there are some facilities that do not have children. They're just adult ART. And we want to encourage those facilities to actually index all those adults that come to those facilities. You check what the status of their children that they're keeping, if we know them, and then so that we can also start them on treatment. Then we have this modality where we want to enhance HIV testing rates among children in remote and underserved communities of Western Province, using the 4 NHCs of Kauman district. And this is to improve awareness about HIV, AIDS, and also importance of testing within the community. The goal is early HIV diagnosis and initiation of therapy. The target population in this case are children under the age of 15 in remote and underserved communities of Western Province in Zambia who have limited access to health facilities. And also, this is more straightforward. It's just going to the orphanages and ensuring that we have the test done, and which is very important. Optimizing PITC, very important as well. And this is to enhance HIV testing rates among children visiting health facilities with undocumented HIV status. And it also helps promote early diagnosis so that the children less than 15 are started on treatment. And so these are usually in any entry point, which can be the outpatient, inpatient, a malnutrition clinic, and even at those accessing NEMA. Then we have got the index testing, which we've talked about and we know about, which also provides an opportunity for testing. So just as an example of Western Province, when we look at the proportionality in terms of what contributes the most to the positives, you find that index testing in this row here where there's a circle is about 49%. And then another important one is this outpatient services, PITC, a very, very significant contribution when it comes to testing. The next one, when it comes to case finding, what is the experience from Luapula? So also Luapula records about 31% of the tests via index contribution via index testing, and also PITCT, although the yield is low, also has a contribution. And then we've got EID cascade, which is being implemented, and also VCT are some of the modalities that they use. What are the challenges? Incomplete documentation and missed opportunities that we're seeing. Weak ID follow-up systems, low yield in the outpatient, under 5 testing, and also limited partner elicitation and male client gaps. Stigma, as usual, a very problematic issue, and as well as stockouts for test kit in the management. What are some of the innovations that we've seen in Luapula? Optimized index testing, family-centered approach, mobile HTS, particularly those fishing camps and villages. Those people will not come to you, but they need to be visited. Youth-friendly testing via campaigns and peer approach. Weekly dashboards for data reviews. I think this is very important. Like I said, we have all this information that we see during our, that we have to use this approach. But if we don't look at our data, it becomes very difficult for us to come up with very specific interventions that speak to the population that we are talking about today. KYCS also is practiced there, and they recommend expansion of testing in PITCT, both VCT as well, via youth and school programs, also using of differentiated models for testing, home-based tents and safe spaces, and also improve ELMS tracking, making sure that commodities are available for use. Strengthen data quality, checks, and mentorship. So Luapula continues to use high impact, community-driven models and index testing and youth outreach at the core. Real-time data use is enabling better outcomes and also on track to close testing gaps and reach epidemic control. So now we look at Lusaka. Lusaka also has shown that index testing about 39% contribution, but also outpatient services also has shown quite a significant positive cases that are contributing to case finding. So here, what we see also now, when we drill down further is that the age less than 5 actually contributes to the highest number of those that are testing positive. So there's something that is missing. We are missing out these children in their breastfeeding period, and now they're ending up with the infection as we meet them when they're 5 years old. So the key issues is knowledge gap amongst the healthcare workers on which children to be tested. Children still have being missed in OPT and MCH. Those are some of the things that they've observed. They've also seen erratic supply of HIV test kits, HIV testing being left to community-based volunteers only, and then also caregivers not available to give consent for HIV testing when children are taken to a health facility. And then also poor documentation of prior to HIV test results. How do we overcome these challenges? I think capacity building among healthcare care workers is very important through mentorship and virtual meetings, development of SOPs and IC materials, specifically for PEDS case finding, and engagement of key stakeholders such as school head teachers, DEBs to provide HIV testing in schools. Then also strengthen HIV testing during Child Health Week campaigns, strengthen and certification of healthcare workers as HIV testers. That way they can supervise the CVVs. Strengthen HIV testing in the community for children by go to follow-up contacts of index clients. Prioritizing the available determined to test children also is another important strategy for consideration. Strengthen the documentation and the issuance of HIV test results slip. Yeah, that should be regardless of the results. Social network testing for adolescents has proved itself to be quite an important avenue to increase the testing yield. Okay, so my final remarks after this presentation, and I would like to emphasize, consistent data monitoring to guide investment decisions is very important. Once we look at our data, then we're able to decide where we're going to invest, where we're going to put HR, which HR we're going to train. What do we need to put in place so that we can improve and close the gap, a treatment gap for children? Index testing in all its forms is the cornerstone to closing the gap in pediatric case finding. I think that's a far-gone conclusion, because you can see from the 3 provinces, they've all said index testing has been quite significant in terms of contributing to the number of positives. Promoting PITCT on outpatient department and inpatient department is very important, and also healthcare worker capacity building to conduct effective testing, counseling services. Strengthen documentation of testing results, and also strategic community-based approaches that target marginalized and vulnerable groups of children. So this ends my presentation, and I hope I wasn't too fast. We'll be able to figure out something, and ask Dr. Mngomba now to take up the rest. Thank you so much.
Thank you very much, Dr. Kozia. This was very insightful presentation. And to learn today, I mean, we are now learning about Know Your Child Status plus, which is some kind of a new concept to other provinces, as well as the hotspot mapping in the fishing camp, like the case of Luapula, This is very insightful, and today's echo, Dr. Ziambo, is so insightful, and thank you very much. Network, we are going back to our poll question before we have comments. So go back to our poll question one, just to do the repo and assess if learning has taken place. So this is our poll question number one. We've launched the poll, and it reads, globally, around 63% of the 1.7 million children living with HIV know their HIV status. Is it A or B? Okay. So far we are at less than 50%. The good part is that our network is very much engaged, and in the next 5 seconds, we should be above 70%. Network, 5 seconds remaining. Okay, so we are ending the poll in the next 3 seconds. Okay, what is the correct answer? What is true? I mean, is it true or false about globally around 63% of the 1.7 million children living with HIV know their HIV status? So we'll end the poll. Just for your comments, Dr. Kozia, on what has been given.
So that's according to UNAIDS data to December 2024, 63% of 1.7 estimated children living with HIV know their status.
Thank you.
So this is true. The statement is true.
So the statement is true.
Yes.
So thank you. Network, the statement is true. So we are going to our poll question. Poll question number 2. Okay. So it reads, over 80% of the estimated children living with HIV know their status. Over 80% of the estimated children living with HIV in Zambia know their status. Is it true or false? Okay. This is very good engagement. We'll end the poll in the next 7 seconds. The question reads again, over 80% of the estimated children living with HIV in Zambia know their status. Okay, so we'll end the poll here. Dr. Kozia, this is...
yes, so 82% of children in Zambia know their HIV status.
Thank you.
That's the true statement.
That's the true statement. So 74% at poll for yes. So we'll go to our last poll question, which we need to provide the answer which is not correct among the 4 provided responses. Okay.
So I know this one is very... So the correct answer is D.
The correct answer is D.
Yes.
D is the correct answer. Nice.
Okay.
I would like to share the answer from the network. So D is the correct answer because really incomplete cascade contributes to case finding. Yeah, I mean, as a barrier, if you do a good cascade and you follow the children, then it means that you'll be able to capture them and add to the case finding.
The case finding.
Yeah, thank you.
Thank you very much. We are ending the poll. A guidance has been provided. D is the correct answer. So we are going in our chat box just to see if we have some questions here. Okay. So we have a question from Mulenga Nguni from Lufwanyama. Considering us in rural areas, I think more attention should be given in order to support us conducting index testing, as most of children living with HIV are missed due to long distances. Okay, thank you. Your point is taken. PK, great presentation. It appears from the issues have already been identified. Is there an evaluation plan in place to collect data and check how each entry point is performing with regard to EID that includes OPD, children clinic, and outreach services? Okay, so have we left out? Okay, so there is also another comment from Isaac Tembo. Could reforming age for consent laws to allow minors to access testing be a significance reaching out to children with HIV testing? So this is Isaac. Okay, so we have these two questions from the network. Before we go to answer them, experts on the call, are you able to unmute and give your comments? Experts on the call?
Yes, Dr. Mungomba.
Thank you, Dr. Bupe. Please go ahead.
Good afternoon, everyone.
Your comment on the presentation as well as responding to the question.
Okay. Good afternoon, everyone, and thank you, Dr. Kozia, for the presentation. Apart from the issues that have been raised, I think it's also interesting how we need to, with the KYCS++, the one that is engaging men, if you look at some data that we're receiving from the men's clinic, where we're having men bringing in their children, we're actually receiving some good numbers from here. So this could be a game changer for us. So male involvement really is encouraged, as well as the discordant couples. But IPD and if you look at the malnutrition wards, we're not testing our children. So basically, we just all need to identify any area. I think just putting a focus for our healthcare workers that any opportunity you have to test the child should be taken, whether they're coming in for a toothache, for malnutrition, let's use every opportunity, because all those to us, to the program, are missed opportunities. And then we'll start seeing positive young children and adolescents who already may even be sexually active and passing on to fellow young people. So I think those are some of the comments I wanted to make towards the presentation. But on the chat, I had started answering just one question about the age of consent. Dr. Kozia can give more details on how far this has gone. But I think it's safe to say that when it comes to age of consent, it's a bit difficult to push for age of consent because of all the jurisdictions that surround the law and how it was framed. But what we are trying to advocate for is the age of access. How can we advocate for changing the age of access to access certain healthcare services, such as HIV testing and family planning? That's what we're currently trying to advocate for and push for. Over.
Thank you very much, Dr. Musonda. This is very insightful. Before we move to the second question, Dr. Muya and Dr. Oscar Mwinde, if you may kindly give your comment to the presentation.
Okay. For me, this is Dr. Nia. What I would like to say is that there are a lot of very good strategies that we have in order to improve on case finding. But I think the biggest problem so far that we have observed is, are we implementing what we are saying?
Yes.
So we need to be very honest with ourselves. Are we actually doing what we are saying we should be doing? Because we have gone to some facilities where you find in, for example, children who came in OPD, they have unknown status. Then you go to the HTS register, you don't find them there, meaning that they were not tested. So if we are going to really improve on case finding, not because we need numbers, but because we need to approach children on treatment for them to grow well, we have to make sure we implement as we discuss. We should do, what do they call it? We should walk the talk. That's the only way we can ensure that our children are found and they are put on treatment. Thank you, and over.
Thank you very much, Dr. Muya, for that emphasis in practicing what we are currently learning. That is a core to all the healthcare workers actually on the call on this call today. Dr. Manzi, if you're on the call, do you have any quick comments? Okay. Okay, so would invite provinces. Provinces, you give in your comment before we open it to the network for questions and answers. We'll go to Western Province. Any comment from your end, followed by Eastern Province?
And Muchinga.
And Muchinga. Thank you, Doc. And Muchinga. Western Province, kindly unmute and go ahead.
Thank you very much and good afternoon, network. Francis Samria, community and HTS lead from Western Province. Yeah, that's very insightful presentation from Dr. Kozia. And as Dr. Muya said, we just need to reinforce testing from all entry points and also make sure that we implement all the strategies that we are putting forward to make sure that we reach out to children and find that are still remaining in the community and put them in treatment so that they have a brighter future ahead of them. Thank you.
Thank you.
Thank you so much.
Thank you. Thank you. This is much appreciated, Francis. Eastern Province, your quick comment in a minute.
Thank you, Dr. Wezi here from Eastern Province. Yes, I'd like to agree with my predecessors. I think it's something that we need to work towards as units within our provinces, but even learning from each other. I know there are a lot of strategies that have already been in place, but sometimes it's not about the strategies, but it's about how we implement it. So something that worked well in Western Province can still be tweaked and made more applicable to Eastern Province. I think it's not just about one shoe fitting everyone or the same, but as long as we implement all the different strategies and make sure that we're putting our efforts towards finding these children, then we'll definitely find them and put them on treatment. Thank you, my submission.
Thank you very much, Dr. Wezi. That's much appreciated. The emphasis on application of what is set as standards is quite key. Muchinga Province, your comment?
All right, thank you so much. This is Dr. Kayamba, the provincial lead mentor under Muchinga. And yeah, so just something to add to the discussion. For Muchinga Province, when it came to our experience, I think we shared it a bit late with Dr. Ziambo. So what we did earlier on is we wanted to do an analysis on finding these same pediatrics. So our two questions that we had is which child are we really targeting? And then the other question that we had was which mother are we supposed to also be targeting in this whole thing? And I think most of the things have been spoken to already, but from the provincial data, what we found out mainly was most of the pediatrics who were infected in Machinga province were between the ages of 1 to 4. Yeah, so they represented like three times more than any other age group within the pediatric age bands. That is less than 0, 1 to 4, 5 to 9, and then 10 to 14. So we had a lot of them between the same 1 to 4. But we haven't just done a final disaggregation to see which actual age groups between that 1 to 4 are actually infected. And then from there, we actually made a conclusion that most of this could come from the seroconversion, as earlier on discussed by Dr. Ziambo, that we have a lot of mothers who are seroconverting during breastfeeding and ultimately infecting these children. So seroconversion is one of our major challenges that we're thinking, which led us now to audit which mothers are coming and seroconverting. So when we did an analysis, we found that mostly it's the adolescent girls and the young women between 15 to 34. Ultimately, these end up causing these children to get infected. And we found that low PrEP acceptance in the same age group was one of the challenges, and we're thinking, could KBLA help to bridge some of these gaps? And then also the reason why these women could most likely infect their children is because they're most likely emotionally mature, they can't take care of themselves, can't take care of the baby, they're also financially mature, they're unable to take care of this baby as correctly as they should. So some of the strategies that we had, in addition to the KYC that has been talked about, was issues to do with maternal retesting. I think if we were to do our maternal retesting very correctly, as we should do it, we would find these mothers much earlier and ultimately link them to care before they infect that child, and do KYC for any other child that they might have been breastfeeding before they were actually diagnosed. Then also, what was the focus where we can find these children? So currently our focus is targeting places like UCI, where we have a lot of these children going for growth monitoring, also immunizations. So if we're able to reach out to those communities, find these children and then test them, we could find those children that haven't been found yet as being HIV positive. Then the other issue that we haven't had a proper SOP when it comes to KBLA giving in pregnant and breastfeeding women. So if we have a lot of women that are converting in those ages 15 to 34, if we're to implement full like opting out, where we give PrEP to these women who are coming through, and then they're able to opt out if they're not comfortable with it. But if we're to give them PrEP like KBLA, would we end up reducing the chances of them getting infected and ultimately the chances of them infecting the child who is breastfeeding? Yeah, so those are some of the issues that we have been discussing, and we just thought that the network should know about them. Over. Thank you.
Thank you very much, Dr. Kayamba. You've brought in another dimension. Maternal retesting is actually key to identify these children. So we are now moving to...
There's a hand that has been raised for a long time.
Yes, please. Thank you very much, Doc. We'll open it to the network now to ask questions.
I think we can have this hand and then we have a case.
The case. Oh, okay. Andrew Colino, please kindly unmute and ask your question. Andrew?
Yes, good afternoon, Doctor. Good afternoon, the panel and the network.
Good afternoon.
Okay, mine will be quick. I'm from Northwestern Province, heading Persons with Disabilities Access to Health Organization. My point is just on an emphasis of confidentiality. It's not really a question, but I just want to emphasize to you, Doctor, please, it's important, keep re-emphasizing on confidentiality, especially for us who are handling persons with disabilities. I thought it's important to bring it. Very important as health providers, health professionals. Thank you.
Thank you.
Thank you very much. Much appreciated. If there is no confidentiality, the level of stigma will go high. So it is actually important to stick to confidentiality. As guided, we are going to our next step, which is the case presentation for today. Very insightful, coming from Senanga, Western Province, which will be done by Maliwa Likezo. So as the slides are loading, Western Province, just a quick comment on how you are documenting the KYCHS++. How are you dealing with the documentation? Just a quick comment for other provinces to learn as well.
All right, thank you very much for the question. So as Western Province, we developed a register, that KYCH++, that is helping us monitor and capture the data of the children that we are reaching out with modality. And this has helped us to reach out to a good number of men, and we have some positives that are coming in through this modality. Though we still have some challenges with some facilities that are yet to implement the register and to implement the strategy with full force, but it's working for us, and we're finding positives. Thank you.
Very much. Thank you very much, Western Province. That is a very good initiative. Senanga, may you load the slide? Nathan, you can go ahead.
Thank you very much, Dr. Mwomba. Wow, they are loading the slide. Thank you very much. Great presentation, Dr. Ziambo. So I wanted to find out the guidance based on that submission, Dr. Ziambo, regarding registers now. Now that we have a register again to help us capture KYCHS++. So what's the guidance to other provinces? I know that's a very good initiative. Now, in view of the guidance that we have, I think, enough and adequate registers for now, of which we're trying to reduce on the number of registers. So what's the guidance now? Do we also go the way the other?
Nathan, so the thing is, we were sharing best practices, and this is a practice that Western Province has actually demonstrated that is working for them. This hasn't really come from the national level, and we're actually learning that they're actually doing something like this. So we're actually learning from them how they're doing. At the moment, we haven't made any decisions to have another register. So we just have to find work out mechanisms, and I know that we can introduce another one. We have to find mechanisms on how we can actually effectively conduct this activity. Yeah, for now, that would be what my comment. Thank you. I think.
Thank you very much, Dr. Koza, for the guidance. Nathan, I hope that is clear. So far, that is what is being done. So, Maliwa Likezo, you are under Senanga General Hospital and you are presenting a case to us. Please kindly go ahead. Maliwa, kindly unmute. Okay, we can't can't see Maliwa on the call. Western Province.
So Maliwa is having some network challenges. Dr. Winnie Chirufya will go ahead with the presentation.
Thank you very much. Dr. Winnie, please kindly go ahead.
Okay, good afternoon, everyone. And good afternoon, network.
Good afternoon. Thank you.
Okay, so I'm going to present on behalf of Senanga General Hospital. So this is the history. We have male 14 diagnosed and initiated on ART on the 28th of May 2025.
Oh, yeah.
Sorry, I've been dropping off. The network is unstable. So like I said, this is male 14 diagnosed and initiated on ART. That was 28 May.
Okay, I think we have issues with the presenter. We are taking it up. So we have a male 14 diagnosed and initiated on us. That was on the 28th May 2025. It tested positive following the mother visit at the facility with the client himself and his sibling. So
Hello?
that was.
Yes, she's back.
Yes, please.
Go ahead, Winnie.
Okay. So the HIV testing was done following the mother's visit, the facility with the client and the sibling who was on ART. So the mother had gone for a routine ART visit, and the clinician attending to her noted that the child was small for age. They had rash and fungal infection on the skin, and they inquired more about the HIV status of the children, of which it was reviewed that the younger sibling, who is 9 years old, was on ART since the age of 6, and she was diagnosed when she was sick. So the mother is said to have been diagnosed through PICT at OPD 4 years ago, and no indexing was done. So the client was screened and diagnosed with TB clinically, supported by X-ray findings, the symptoms, and was initiated on TB treatment on the 29th of May. So the birth history was unremarkable, developmental milestones were normal, and the immunization status, the child had completed immunizations. Under nutritional history, the child was underweight. Past medical history, there was no history of any HIV test result or recorded for the child. Family history of note is the sibling who's 9 years old, who's HIV positive and was on ART. So on the physical examination, the child was looking sick, the vitals, temperature was 36.5, the weight was 22 kgs, the height was 122, and the BMI was 14.8, which was below the normal for the age. Then head to toe examination, the hair was brown, and then the skin, the eyes, the mouth, the chest, and the abdomen, we can see that the skin was dry with rash, and it was also peeling. The eyes were normal. The mouth, there was normal. There was no ulcerations or any candida. The chest was clear. The abdomen was a bit distended. And then the neuro exam was normal, and the musculoskeletal exam was normal as well. Next slide. So these were some of the investigations that were done on the 28th of May. We see that the CD4 was 253 copies. The serum CRAG was negative. GeneXpert was negative. Or is it MTB was non-detected. Then the HB was 10.6. And the viral load copies, we see it was 1,459,000. RPR was negative, and hepatitis surface antigen was negative. Then the child was started on ABC, 3TC, and DTG. Next. So these were some of our questions. How can we effectively conduct family index testing to ensure that all children in this household have their HIV status known? Number 2, what could have led to the missed opportunity to test this boy much earlier, and what measures should the facility institute to avoid late diagnosis of HIV in children? The third one, what additional support can be given to this child presenting with advanced HIV disease?
Thank you very much, Western Province team, for this wonderful presentation. Just a quick summary. We are dealing with a male 14 who visited the facility with a mother for an HIV test. And that was on the 28th May 2025. This child was looking ill, small for age, with a skin rash. The mother mentioned that he has only one sibling who has been on treatment for the past 3 years, and herself, as the mother, she was diagnosed HIV through PITT model at OPD. And our male 14 was also screened for TB and was found TB positive, suggestive using the X-ray. So BMI actually showed that this was low for this age. It was at 15.8. So now the question we have, can you go back to the questions? We have 3 questions which we're asking as a Senanga team to the network. How can we effectively conduct family index testing to ensure all the children in this household have their HIV status known? Secondly, what could have led to the missed opportunity to test this boy much earlier, and what measures should the facility institute to avoid late diagnosis of HIV in children? And lastly, what additional support can be given to this child presenting with advanced HIV disease? So these are our 3 questions. So we open it to the network for you to ask for clarity so that the facility can clarify, then we'll go quickly to our questions. Network, kindly unmute and ask your question. Okay, so Namukonde, you are inquiring about the viral load. It was 1,400,215. Bearing in mind that this was the baseline viral load to this child. Okay, and CD4 was 253. Yes. Serum CRAG was negative. Okay. Any clarity? Is everything clear on the case presented? Okay, so that's very good network. We can go back to our questions. Kindly go to the questions we have as Senanga. Great. So network, what is our view on question number 1? How can we effectively conduct family index testing to ensure all the children in this household have their HIV status known? Network. Kindly unmute and okay, Nathan.
Thank you very much, Dr. Mwamba. Very nice case indeed, something to learn from. Maybe so I can start with my submission. So based on the presentation, the indexing was initially it was not done when this woman was identified HIV positive. If I got it very well, the indexing was done 4 years later, which I think it was a very missed opportunity. So maybe how we can do it better is to, as soon as possible, as soon as this woman is identified HIV positive, right there and then, we start the elicitation. And actually, we encourage indexing being done even before someone is tested for HIV. It's actually part of pre-testing counseling session. Just as we do pre-testing counseling, we also incorporate indexing and also elicitation. So in that way, I think will be very much effective, other than letting it up to after 4 years. That's when we decide to index this woman and then start eliciting for a child. I think we can close that gap if we just start as soon as possible. I submit.
Thank you very much, Nathan, for this comment. We have another hand up. Dr. Margaret Chimba, please unmute and go ahead. Dr. Chimba. Okay, so we can't have Dr. Chimba, you are not able to unmute. Great response, Nathan.
Can I comment something?
Yes, please, kindly go ahead. Francis,
okay, thank
please
you
go ahead.
Yes, thank you very much, and thank you, Senanga, for the presentation. And Senanga has told us that one of the siblings to this client was already on treatment, meaning some index were offered, but were suboptimal. That's why maybe for us to enhance case finding and index testing services is to optimize it, to optimize family index testing. That's why as Western Province, we brought in KYSH++. Remember that every woman that tests HIV positive, we either follow them and offer them KYSH+ and test all the children that are living under their household. But sometimes we find that these children usually move and tend to go away. In cases where couples are separated, sometimes children live with their fathers and others will be living with their children. Even when they have been offered index testing services, some of these children will still be missed because they are not in that household that will go and test. And with time, when time passes on, they could have been enlisted, put in the register, but as time goes on, we haven't reached up to them to test them, we miss them, and they'll fall off in the backlog. But that's why now, as Western Province, we make sure that we come up with KYSH++ to make sure that we reach out to everyone, every children, those that are living with their fathers and those that are living with their mothers, so that we don't leave out anyone. As Nathan has said, really we need to enhance index testing or offering of information in pre-test counseling so that people know why, and they'll give us the names and we'll reach out to them and test them and ask if there are children that are not under their household currently at that point in time, so that we devise means on how to reach them and offer them HIV testing services. Over.
Thank you. Thank you very much for this feedback and updates on what you are doing as mitigation to the gap which was observed in Senanga and other part of Western Province. So we are moving to our second question. What could have led to the missed opportunity to test this boy much earlier, and what measures should the facility institute to avoid late diagnosis of HIV in children? Network, over to you. Kindly unmute and help the Senanga team to do it better. Okay. Okay, so Dr. Koza, may you help to chip in on this second question?
So what could have led to missed opportunity to test this boy much earlier? What measures should facility institute to avoid late diagnosis? So if we look at the presentation, what we're looking at is where are we getting the most positives? It's in index testing and in PIT, in OPD and inpatient. So if there's a place where we need to structure ourselves is in those places where in the PITC, in the OPD, have we set up good referral systems in that place? Do we have at the facility level? Do we have someone responsible for ensuring that every person that is seen know their HIV status? And they need to know their HIV status. And if they don't, they receive appropriate counseling. That's the one thing. So the first thing is about how do you manage our patient flow within that facility to start with. And I think that's what Senanga needs to do, work on their patient flow. Then the next thing is, after doing that patient flow, then do we have the right capacity? Can every nurse, every CBV that is there, can they conduct a test? Sometimes they come at night and you find that the certified tester is not there at night. And so they need to refer the person to come back the following day. So in that case, we're losing those opportunities and we're not able to do that. And so, and then, I would agree with Nathan, when we see the people that are already living with HIV, we need to index them there and then, and we need to counsel them. Very effective counseling. Do we have the right SOPs to help us manage that process? We have the information to manage that process. So those are some of the things that I would quickly sort of contribute on responding to question 2.
Thank you very much, Dr. Kozia. This is really insightful, and looking at the way the data presenting itself, it is really the way to go, Senanga. So question number 3, which is the last question: what additional support can be given to this child presenting with advanced HIV disease? What additional support can we give to this child?
I don't know if Dr. Chimika is around. Maybe he may make a comment.
Oh, okay. Yeah. Dr. Chimika? Dr. Chimika, may you kindly unmute and help the network?
Hi. Are you able to hear me? Sorry, I was distracted. It's in another meeting. Just repeat the question. Sorry, Dr. President.
Yes, Dr. Chimika, we'll repeat it. We are on question number 3. What additional supports can be given to this child presenting with advanced HIV disease?
Okay, so thank you very much. I'm not sure what has been mentioned already, but as you may be aware, we have a package for care of children with advanced HIV disease, and already I've seen that a number of things that needed to be done have been done already. But remember, I'm not sure about whether this adolescent is in school or not, right? And in addition, he just started treatment, that's May. I think this is a parent or an adolescent who may need a lot of support, including the parents. So if there's a provision where we can link them to peer support groups, for example, there are those groups where mothers with children living with HIV could be linked to, so that we strengthen adherence. I know it's just in May, adolescents have their own needs and challenges, so it would be nice to link them to adolescent support groups if at all it exists in the catchment area. I believe this will go a long way. He requires a lot of emotional support. And also, I'm not sure if some of the skin conditions have been addressed, right? And above all, the nutritional support. This adolescents, the BMI was 14.5, right? So we may need to ensure that we provide appropriate nutritional support to this adolescent. And I think somebody has just like read my mind. I didn't hear whether, I didn't get whether disclosure was done to this adolescent. If it was done, well and good, but it requires a lot of support. Okay, if no disclosure has been done, because at 14 years, I believe the consent was given by the caregiver, who's, I suppose, the mother. So those are some of the issues that I would want to add on, but it requires, because he may have a lot of questions, okay? And again, I just want to highlight that it's a missed opportunity. I don't think this adolescent is the first time to access health services. I believe he could have accessed for a different reason, but the health providers, we understand when we are training pediatric HIV, let's make use of the information that we learn, because the modules are very rich, and one of the manifestations of HIV infection is stunting and all those things. We should be suspicious that this is 14 years, but looks thin, looks small. Think about some chronic conditions, and HIV should be one of them. Of course, there are social issues, but let's not miss HIV. Thank you very much. Good presentations and good case for discussion, Dr. Kozia.
Thank you, Dr. Chimika. Dr. Chu. Thank you. Dr. Chalilwe, please kindly go ahead in a minute.
Yes, thank you. I just wanted to add on a bit to what Dr. Chimika said, that this child should have interacted with MCH at some point. So if you look at, for example, we said that this child was small for age, but I just wanted to focus on something that we need to be looking at, and that's quality of care. So even when we're looking at the indices of this child, for example, we have a weight, we have a height, and then we have a BMI. So we could have gone further to look at a height for age to sort of see and quantify that stunting, which, as Dr. Chimika said, helps us say, okay, what can be causing a child to be looking like this? Also, we diagnosed TB in this child. It would be good to get additional history of where that TB came from, so that we do some reverse contact tracing to see what the source of that TB could be. Obviously, it's a 9-year-old child, but there could be someone within that vicinity that could be there. And then also just nutritional history. We can just dig a bit deeper. Usually underweight issues we pick from the examination, but under nutritional history, we're supposed to be looking at food security issues that this child could have. And also just to say, if we dug a bit deeper also into some of these skin infections, to just see that we are looking at this child holistically as well. It's very interesting that the smaller child is on treatment, then this one who's older was never indexed. So all those are things that the team can probably look to see and just comb through the ART clinic to make sure that all the adults have their kids indexed as well, including KYCS++. Thank you.
Thank you very much, Dr. Chalilwe. Quite timely. The reverse the TB support and screening, very, very important. Senanga team, Western Province, feedback has been given for your consideration on the 3 questions which have been asked. Ensuring that index testing is done, which was a missed opportunity. We have also the facility ensuring that PITC and index is actually strengthened, and also on the issue of advanced HIV disease screening. You did actually very well. You did screen advanced HIV, and you had to also screen for TB, so which made you to activate the package. So what is also important is to ensure that we have a post-care, a post-discharge care follow-up for this child, 2 weeks and at 1 month, so that we see how this child is improving. Quite important. Any comment from your end, Senanga, in a minute?
Okay, thank you very much. I think we've learned a lot from the team. Indeed, this was a missed opportunity, and it tells us that we have a lot of people who are out there who can be in a similar situation. So going forward, we'll do better and see if we can find these cases quite early. Thank you.
Thank you very much. Dr. Kozia, just in a minute, if you have a comment.
No, thank you very much, Senanga. You've presented a very practical experience, knowing very well that you had some missed opportunities, but you're able to share a case like this, and we're able to learn from there, and we're able to share some lessons. Thank you very much. Thank you, Namkonde, for your comments in the chat. Quite exhaustive, some additional support that you've included there. And I think I like your regular monitoring, emotional support, education, and training. Very important for this child to be able to have a better quality of life. So in short, in a nutshell, colleagues, let's put into practice all these strategies that we have. Let them be in our facilities, and in our facilities, let's respond to data that speaks to some of these things that are happening in our facilities. Thank you very much.
Thank you very much, Dr. Kozia. Looking at the presentation which you've done today, you've shown to us the general picture at global level, Zambia level. You went ahead into the challenges we are having. After that, you talked to us about the strategies, where you talked about the EID index and PITC. You also went ahead and showcased to us the hotspots mapping in the fishing camp, as well as the strategy which is being used in Western Province. After that, you gave us the strategy with emphasis to data index and PITC in OPD and IPD. So this was really insightful. Network, we are very thankful for your participation, and also here from the hub, we have actually members who came and joined in physically. We are also thankful to you all for coming in and join us physically. We are committed to deliver to you as ECHO team and ensure that the knowledge is actually shared. So for now, until we meet on Wednesday with the long COVID ECHO, and Thursday with advanced HIV ECHO. So please, network, let's encourage others to join this ECHO platform. A lot is being learned, and we are very much assured that as Zambia, with this ECHO platform, we should be providing quality care services. Once more, thank you very much. We are saying bye for now, and thank you once more, Dr. Kozia.
Thank you very much.